Hi everyone, hope you're all kind of arriving and getting settled in okay. Welcome to our session this morning on fatigue management in COVID. So I'm Helena, I'm one of the physio here with Joan and Ellie. I don't know if you guys want to pop in and introduce yourselves briefly.
Yeah, I'm Joan. I'm the occupational therapist in Tower Hamlets and NEL. That's me.
Hello, I'm Ellie. I'm a speech and language therapist by background, and I'm sort of doing a condition management role. I think it's a little bit of a misnomer to say I'm a speech and language therapist in this team, but yeah, I'm doing condition management and some SLT in City and Hackney.
Yeah, similarly to Ellie, I'm a physio by background, but kind of work in service as a specialist AHP, so sort of condition management work with people. So Joanna, if you don't mind just moving on to the next slide, I'll just kind of outline what we're kind of hoping to cover in our this afternoon. So we kind of got briefed a little bit that we're primarily sort of presenting primary start there. Oh, message saying my voice is in and out. Let me move a little bit closer to the mic and hope that that deals with the problem. Please do let me know if that happens again if I relax. So yes, we thought we would just sort of start this session with kind of, I guess, outlining kind of long COVID standabout fatigue, as well as kind of exploring a little bit about the role of primary care in that. Then got a short section kind of signposting resources we feel could be in sort of primary care setting, and then going on to kind of what we do as kind of specialist rehab services, how we might support people that are living. And kind of in amongst all of that, we're kind of looking a bit about kind of and brain fog. So hopefully that's what you're all expecting. We will have some questions session as well. So if you didn't mind just moving on to the next one. So I guess just to sort of set the scene, really, there's quite a few different terminologies and definitions sort of around COVID and COVID. So acute COVID-19 is defined as the sort of signs and symptoms of COVID-19 infection from 0 weeks. And then we've also got this kind of definition of ongoing symptoms of COVID-19. So that's the signs and symptoms that might sort of persist sort of from 4 weeks to 12 weeks. It can be really normal for symptoms to linger around after a COVID-19 infection for that sort of time frame. And that can be, I guess, really useful knowledge to patients that might be worried about kind of persistent symptoms at that point. That can be really normal following an infection. And then we've got post-COVID-19 syndrome, which is the signs and symptoms that may develop kind of during an infection, but sometimes they might kind of be quite different to what stages. They might sort of develop in that sort of recovery period afterwards. And they're the symptoms that persist sort of more than 12 weeks after an infection that can't be explained by an alternative. I guess that kind of little end bit is where we're sort of basing our kind of work and what we feel is really important for you guys to know as primary care practitioners. And then long COVID, I guess, is a bit of a sort of umbrella term for sort of those symptoms that are persisting sort of after the sort of 4 weeks, but sort of beyond the 12 weeks as well. The next slide, Joanna. So we've just got here a kind of word cloud that we've taken from one of the introductory kind of webinar sessions that are referred to our service in City and Hackney. So we ask patients to kind of share with us what symptoms they're experiencing. The more a symptom is kind of input into that, the larger it might appear. And as we can see here, fatigue and brain fog, predominant symptoms kind of coming through. And this correlates with kind of the most recent sort of numbers that we have from the Office of National Statistics, with 72% of people with long COVID reporting fatigue as the most common symptom, closely followed by 51% reporting brain fog. And a large percentage of those people kind of experiencing those symptoms and others report kind of significant impact on their ability to do day-to-day activities. So while it can be really common for symptoms to persist sort of that sort of 4 to 8 weeks post sort of virus, it's really important to recognise when it is persisting beyond that and becoming quite problematic for their ability to kind of function day to day, during kind of when further support services like ours might be beneficial, and how to go about linking in with us. I'm going to hand over now to Ellie, who's just going to help define kind of fatigue and brain fog a little bit more for us.
Thanks, Helena. Yeah, next slide, please, Joanna. Thank you. So yes, as Helena said in the first one of the early slides, we're looking at fatigue as the symptom of tiredness which persists after resting with no other diagnosis. So where we're really reliant on our primary care colleagues to kind of work that out a bit for us. So we're talking about fatigue as being this exhaustion, and it affects physical activity, emotional, social and cognitive functions. It's quite broad ranging. People often experience a worsening of their fatigue symptoms post-exertion, and that might be delayed post-exertion as well as immediately post-exertion. And patients' descriptions of this is it's really they're very vivid, as sort of this treacly feeling in their bodies. Someone said the spark is gone, just this sort of motivational spark's gone. And a lot of people are sort of describing this slightly dissociated sensation of sort of sitting back and not being able to do things, not sort of having this energy, this internal energy to kind of get going. And then when we're talking about brain fog, it's a cognitive symptom which has some fluctuation. So we're not seeing it the same sort of patterns that you see with like a sort of a discrete acute brain injury or stroke or something like that. There's some fluctuation, and so there is a link with fatigue. There's a UCL study which is saying, well, it sort of might act in combination with physical fatigue. People's cognitive symptoms might get worse, but also it can act alone. So cognitive exertion can result in this sort of fogginess that people describe, which sort of describe this. This is a study of symptoms, the Davis et al. Study. And I think breaking down what they mean by this difficulty thinking, it's reduced attention, reduced sustained attention, difficulties with recall and working memory, and a kind of general difficulty thinking, which seems to be about slowed information processing and reduced executive function around problem solving and decision making. And then word finding difficulties, which feels a bit associated with this slowed processing and recall rather than a kind of an aphasia. And I guess in the absence of another condition, and I know Joan's going to sort of explain a little bit about our differential diagnosis, our kind of working hypothesis about what's going on is that fatigue is, as in ME/CFS and other post-viral fatigue and fibromyalgia, that this fatigue is due to autonomic dysregulation, essentially that the threat system is super active and responsive or staying very active. There's lots of sympathetic nervous system activation. Physically, people are going into anaerobic activity much earlier. I think there's a lot more limbic system activation cognitively. And so this is really exhausting activity. So things which have felt completely normal, like writing a shopping list and going to the shop, now suddenly feels like a sort of an exam and a marathon. So it's sort of the body is responding as though it's an enormous exertion when it used to feel much more proportionate. And there's less parasympathetic nervous system activation. So it's sort of in that world of dysregulation. I think next slide, please. And just a note, I think this came as a question early on about, well, is fatigue all in the mind? Is it a psychological situation? And I think if we think about this autonomic dysregulation theory, there's a lot of evidence, increasing evidence and suggestion in psychology about trauma and early childhood experiences leading to a lot of dysregulation. So I think sensibly that there is probably some connection with the levels of sort of psychological threat in the body being responded to differently. So the threat systems are more active. There probably is a connection with psychological states, and this JAMA psychiatry paper that I've linked suggests that, and it was looking at nursing staff, but it was saying actually people who rated themselves as experiencing quite a lot of distress pre-COVID infection were 50% increased risk for post-COVID symptoms. So I think we are in this world where there's a correlation, but I think it's really important to sort of note, well, patients are experiencing this very, very physically, and that differential diagnosis can also be made within our teams, because we have across NEL we've got psychology teams working in combination with the physical side, and so we can sort of do some of that unpicking in the assessment. And I think I'm going to pass over to Joan to sort of say a bit more. A bit more.
Thank you. Next slide, please, Joanna. So I'm just going to talk a little bit about the long COVID pathway and the referral process now. This is a pathway from the National Commissioning Guidance for Post-COVID Services, and it just outlines the pathway from, the GP appointment with the patient, with the long COVID patient. In particular, I just wanted to highlight the red area. So you can see there that, I suppose in primary care, you'll consider your holistic review of the physical and psychological health of the patient. And there you can consider the chest x-rays, blood, the oxygen saturations as well. And then you'll move across and see, is there an alternative pathology? Consider your differential diagnosis there, your specialist assessments for specific conditions, and onwards referrals if need be. However, if COVID-19 symptoms last beyond the 4 weeks, then you can start your medical investigations for long COVID. So that takes you into this red box there on the right for the long COVID MDT service. And then from there, we can triage. So I guess in saying that, primary care is such a vital part in identifying long COVID in patients, and then also inherently a big part in the number of referrals that we get in our long COVID service. Next slide, please, Joanna. So we're going to talk a little bit about some of the barriers to the referral process, and this is as reported by patient. And this includes difficulty accessing a GP appointment, uncertainty regarding the long COVID pathway, not being listened to by health professionals, delays in access to medical diagnostics, access to information, and so where primary care can assist, it's providing education on long COVID, leaflets, handouts, and videos that we can provide to display at your surgeries as well. So this might mean getting to know your local long COVID service and what their treatment plans and intervention involves, and also validating the patient experience with fatigue and long COVID and providing support. So this may include an onwards referral to IAPT or to other psychological. Next slide, please, Sean. So the referral criteria for rehabilitation. So for inclusion, we need to see someone who has a COVID-19 symptoms. So not necessarily need to be diagnosed, but just having the active symptoms for longer than 12 weeks. The patient needs to have a GP in the borough, the rehab team. The referring medical clinician has to complete all medical investigation that could attribute to the symptoms experienced. So your mandatory investigation, blood count, but I will go into a bit more detail in the next slide. And also we need to make sure that the correct referral form is received and completed in full. So unfortunately, we can't accept GP letters at all. The exclusion criteria, under 18. So unfortunately, we don't see anyone under the age of 18. However, I know that there are 14 specialist paediatric post-COVID hubs across England that provide expert advice to local paediatric service and support under 18s with long COVID. We also won't see anyone who has experienced less than 12 weeks of symptoms post-acute infection, and where the patient has not undergone a face-to-face assessment in the primary care or the specialist care setting. We also don't see anyone whose symptoms are life-threatening. That needs to be signposted elsewhere, and where a patient has symptoms where an alternative cause has not been investigated or ruled out. Next slide. Right, so in this table, we're looking at the symptoms that we commonly come across in long COVID and the types of medical investigation we need completed before accepting the referral, or accepting the patient into the service. So these are your mandatory investigation. This is just out of our standards of operating procedures, so it's quite similar across the board. I won't go into all of it, but I guess just for fatigue, you can see that the mandatory investigations are your hemoglobin A1C test, your thyroid function test, vitamin D levels, just to be aware of the levels, the B12 serum and folate levels, the bone profile, the brain natriuretic peptide, so the BNP, and also your ECG. And this can present, with a patient saying, I'm so tired all the time, I'm exhausted, or I can't get out of bed. So that's what fatigue might sound like, okay? They may also complain of brain fog as well. And while there's no sort of mandatory investigations for brain fog, you might want to consider a quick cog screen, a MOCA, MMSA, Cognizstat, and if you want to investigate further, then a referral to the memory clinic. If they do present with all of these fatigue, dyspnea, cardiac symptoms and coughing, then we'll need the full work, which is your full blood count, your chest x-ray and your ECG as well. And just real briefly, so a differential diagnosis for fatigue, for example, can include things like vitamin deficiencies, anemia, abnormal thyroid functioning, poorly controlled diabetes, as well as mood disorders like depression, major depression. For shortness of breath, for dyspnea, you might see a new diagnosis of asthma or COPD. And for your cardiac symptoms like palpitations, it might be stress, it might be anxiety, it could be drugs and stimulants, or it could be something a little bit more sinister like arrhythmia or other heart conditions. Okay. Next slide, please, John. So just some take-home messages is that we are a rehab service. However, all the medical investigations do still have to be held by you guys, by primary care. And we're about normalising fatigue in both the acute and subacute stages of COVID-19 virus. Between 0 to 8 weeks after the virus, the support is held primarily in primary care. So then in that case, it's about normalising and validating their feelings and their thoughts, and then linking them to self-management resources, which I think Helena is going to go through in a little bit. If there are persistent fatigue symptoms plus other symptoms are about 8 weeks and beyond, then it's reasonable to commence your post-COVID differential diagnosis process. So ordering of other investigations to rule out other conditions. I guess being aware that it is a lengthy process. The referral process is quite long, and it's just because it's post-COVID syndrome, which is the diagnosis of elimination. It's ruling out these conditions to come to the conclusion of post-COVID diagnosis. And it is important to rule those other things out and to treat these other causes first. And if you're unsure, of course, we welcome any questions or queries. We'll have our details towards the end of the slides, so please do contact us if you're unsure. And I think that's me. I think I'm going to hand over to Helena now.
Thanks, Joan. Yeah, I guess there's sort of further to that as well. It's like, if there are other causes, it doesn't necessarily mean that it completely rules out a long COVID diagnosis with other symptoms. But I guess just trying to highlight the importance that if there are other things that require different types of treatment, it's really important to identify that, but it doesn't necessarily mean that it's not still appropriate to link with rehab services to support if the general picture is looking like it's kind of long COVID contributing to many of the symptoms that someone might be, if there is any uncertainty, please do kind of get in touch. We're really happy to talk through cases and think about if we can support people, even if there is a bit of a mixed picture. If you wouldn't mind just going on to the next slide. So just quickly here, really, before we move, some actual tasters of kind of what we do to support people with managing fatigue. We just thought we would sort of signpost to some resources that might be helpful tools kind of at that sort of primary care kind of part of patient's journey. And so kind of at the top here, I guess, some sort of snappier ones. We've got this guide on how to manage post-viral fatigue after chemotherapy, which kind of really clearly categorises kind of the different stages of recovery and what fatigue might present like in those different stages, and some really helpful kind of tips on what people can do to support themselves as they're kind of going through that, as well as kind of giving some clarity around when it's appropriate to kind of seek further support if things aren't kind of resolving, when to kind of go and get some more support and what that might look like. So useful kind of quite snappy bit of information and guidance there. Hopefully most of you will have heard of the Your COVID Recovery kind of website, but there's a fatigue page there which provides information of kind of fatigue, how it might present, including things like post-exertional malaise or types of fatigue, as well as kind of some of those kind of coping strategies and guidance on when to seek. For anyone that's kind of interested in something a bit meatier, then we've kind of got here, and we've got all these links kind of at the end of the presentation, so hopefully that will all be shared with you. But a bit more of a sort of juicy workbook around fatigue management, which has some sort of interactive sessions that patients can kind of engage with, which can be helpful in, I guess, raising insights and awareness of kind of how somebody's fatigue is affecting them, noticing any patterns in the fatigue symptom itself or their response to it, which can be really useful kind of for building a foundation of kind of then being able to manage that better. And that might be something that they feel that they can go away and kind of do themselves, so sort of going down more a self-management pathway, or it can be really helpful kind of setting up for a rehab intervention, so kind of useful either way. And then we've just popped on here, I know sort of Ellie and I have definitely had like a number of patients kind of coming to service that have found this little booklet on the lost art of convalescence, kind of really validating and helpful in kind of giving a bit of permission to kind of take things a little bit slower after COVID-19 infection and accept the kind of process of recovery and supporting yourself to create a nurturing environment that allows that resources. And I think on the next slide, Joanna, if you mind just going on to it. Joan, I think you were saying this might have come up in a recent sort of one of these sessions, but This is sort of video. There's 2 videos, one sort of directed at professionals and one for patients, that's developed by the Blackpool and Eagleshire Hospital Trust. But they're really happy for it to be used more broadly. So it just gives a really nice overview of kind of what long COVID is, what it might kind of be like to experience, and kind of what to do. So a nice one to kind of like play in waiting areas or share with patients that are presenting with symptoms that might be. Just move on to the next slide. And the next one, title slides in. So a little bit about kind of long COVID rehab services now, from a few different services today. So we each probably structured slightly different, but generally as long COVID rehab services, we're multidisciplinary services that aim to provide practical support. So therapists like myself and Ellie, so physio and speech and language therapists, and then Joan, sort of occupational therapist to service, sort of helping people to understand the symptoms and sort of develop an individualised strategies that help them manage them or live well alongside them, along with psychological therapists, living with difficult symptoms like fatigue and brain fog and all the others that might come with long COVID can result in difficult thoughts and feelings and emotional responses. And so being able to kind of provide support for that side of things as well is really key in kind of supporting the management of a condition like that. We have kind of access to advice and guidance through a few different means. So some of us have a little bit of GP support, kind of like with a small clinic, maybe once a month or a couple of times a month. So if any kind of medical queries or concerns come up during our kind of work, we can kind of take them to those forums for advice. And I think some of us have links with kind of hospital teams and consultants. As we sort of said, sort of primarily we are kind of rehab services, and so that the role of kind of primary care and kind of supporting with the medical side of things is really key and really vital. Move on to the next slide, please. And then just as an overview, I guess what we might support people kind of living with long COVID to do as rehab services is build insight and awareness to help people to make sense of their symptoms and any patterns that might be coming through. From that, we can support people to develop tools that might help them to live well alongside those symptoms. And we often kind of move towards using more values-based kind of goals or interventions in this work. Long COVID is a really fluctuating condition, and there's still quite a lot of uncertainty around prognosis and recovery trajectory. So working towards goals that might not actually be achievable at certain points if symptoms are more kind of flared up can be really disheartening and kind of feed into a really difficult kind of loop. So getting in touch with the underlying values of what people are doing or had to discontinue doing, finding alternative ways to kind of get in contact with that value is quite pivotal in how we might approach the kind of rehab work in conditions like long COVID. Mentioned that kind of difficult thoughts and feelings is a common experience with many that we're working with, so kind of having psychologically informed practice is really important, and that might be sort of through physio and OT providing sort of psychological adjuncts to therapy, or it might be a more kind of like focused piece of work with psychological kind of specialists. And I guess the sort of final piece of the puzzle is kind of having setback plans. So as I've said, sort of fluctuations are really common in COVID, and so helping and empowering people to feel confident in how they manage those fluctuations is part of what we do. So I think I'm back to Joan again now for a bit of a taster of some of those strategies you might work through within our work.
Yeah, hi, thank you. So I don't know how many people have heard of the spoon theory. It's a really popular theory, and it's just a really nice visual way of thinking about, the energy levels, and a way of explaining to family and friends by almost quantifying the energy for the day. So the theory is that you get 12 spoons of energy a day, and each activity of daily living is attributed to a certain number of spoons. So for example, here, going to work or going to school is 4 spoons, making and eating a meal is 3 spoons, so on. If you've had a bad night's sleep, then you start off with 11. If you are under the weather well, then take 4 spoons away. So as you can see, it's a really nice visual way of kind of helping a patient to explain their energy and fatigue levels to others or to themselves. And some of the other theories and resources that we use, so we talk about the 3 Ps quite a bit. Three P's are pace, plan, and prioritize. So using these principles to kind of help to save energy. Pacing being, breaking up an activity into smaller chunks, spreading it throughout the day, or building incorporating rest breaks into an activity. Planning being creating routine, planning ahead, so using your activity diaries and schedules to spread activities out over the week. And prioritizing, so what do I need to do today? What do I want to do today? Anything I can delegate to anyone else? Can it be done tomorrow instead? And what activities make me feel energized? We also talk about a theory called the boom and bust theory as well. And basically it's the tendency to do as much as when you are feeling well, when you're feeling energized and have enough energy, until you have no energy left. And this leads to a feeling of exhaustion, and it might take you a little bit longer to recharge your battery. So you could be bedbound for a couple of days after, or for the entire week. So this isn't what we encourage. It doesn't allow you to be consistently active. And we try to avoid this with patients. We don't encourage them to do this. Alternatively, it's important not to do too little, because they're not going to be stimulated enough in the situation, and it's not going to build up on their strength or their energy reserves as well. Okay. And the last little one is just about energy conservation. And these are just general tips that you can provide to the patient. It can be things like sleep hygiene, so sleeping well, ensuring that they are having the same sleep routine, so waking up at the same time every morning, going to bed at the same time every night, avoiding coffee and maybe electronic devices an hour and a half before bed, keeping the room dark, and avoiding food and drink an hour before bed, things like that, little tips like that. Real quick, just a few other tips would be having things at waist height, so convenience zones, using your arms less and doing things at waist height just uses less energy. So for example, instead of hanging your clothes up on the line, use a clothes airer. With temperature, avoiding doing tasks in very hot or very cold climates, because this tends to decrease your energy levels. So the recommended, I think, is about 19 to 22 degrees in environment. And then resting after eating, because, after we eat, the body requires 10 to 20% more energy and oxygen to digest food. So it's really important you just sit and rest a little bit after you've had your meal. Okay. And next slide, please. I think I'm handing you over to Ellie.
Thanks. I guess taking on from what Joan said with these underlying principles, what we're trying to do with patients is help them sort of understand the principles, the theories, and then also to make changes. So we're looking, I guess, the active ingredient of rehab is behaviour change. And to create behaviour change, we need a few things. We need insight, we need motivation, and we need ability. And here's an example of something that we do, which is a little bit about insight building and about making connections with what's going on with fatigue. And this is an example that a patient did, thinking about where does energy, what kind of energy comes in, and this is physical energy, but also sort of emotional, psychological, social, cognitive, sensory energy. And what depletes energy, what really uses up a lot of spoons, I guess, is one way of thinking about it. And this patient who just, in doing this piece of work of what's nourishing, what's depleting, really started to notice how much this drain of the job that she was doing was feeling like such a forced effort in terms of it not being connected with her values, as Helena mentioned earlier. And then just building some insight into, okay, so what are the feelings in the body? What are the thoughts what are the thoughts and what are the urges and the feelings psychologically that are happening when you've got energy coming in? And how can we take some of these qualities, these nourishing sensations, how can we then sort of bring those into these really depleting activities? And I think doing this, sort of generalizing and making the connections has just been really lovely, a lovely piece of work to kind of build real insight and make and notice what's going on. So I'm going to pass over to Helena to just say a little bit more about behaviour change, I think. On the next slide, Joanna, please.
Thanks. Yeah. So like I said, I think what we found is providing the information on the sort of strategies and tools can be really helpful for some, and for others, they can get it. Excuse me. But sometimes the sort of application, just that's where we've sort of drawn on some of the behaviour change theory, explore how we can support people to overcome that hurdle. And Ellie's spoken about some of the tools that we use to sort of build those insights. And then these are just some examples of then how we sort of think about those other components of behaviour change in sort of like motivation and ability, which you can see on that graph there. And if we can kind of make some tweaks and changes, or kind of explore some tweaks and changes with people that kind of help to increase the motivation and make things easier to do, then hopefully we kind of support them to kind of get into this action zone where change can happen. So sort of spoken a little bit about kind of what we might look at to sort of explore that motivation kind of component in terms of what are the underlying values of kind of when you used to do this activity, and how can we find other ways of kind of getting in touch with that now while you've got these symptoms that are making it different or more difficult. And then over on the right hand side of this slide, we've got a tool that might kind of help people to explore the ability kind of component of changes. So this is sort of an OT model called sort of PEA. So it looks at kind of what's happening for the person in a task, what's going on with the environment, and what are the details of the activity itself, what are the parameters, and then thinking about what can change. And it's not to give people a to-do list of all these things that they need to kind of go away and kind of make changes and practice. Hopefully just opens up some choice for them about what feels workable in different situations at different times with fluctuating symptoms. And so hopefully kind of starts to move people towards feeling empowered and having choice in how they kind of operate and apply some of the I think if we move on to the next slide, we're just sort of rounding up before we kind of open up to some questions today. So I guess the takeaway messages that we would hope you might absorb from this session is that fatigue is one of the most common following a COVID infection, and it's quite common for it to be sort of persisting sort of beyond perhaps usual recovery trajectories in other viruses. So sort of from a primary care view, validating and reassuring and providing some information about what is normal, really empowering and useful in those sort of acute and subacute state of COVID-19 infection. But that when it's persisting and when it's more severe, it can be really debilitating for people, affecting their sort of social lives, their working lives, their personal lives. And so in some situations, information on its own might not be enough, and then rehab services can really support in how to develop and build more personalised kind of strategies to help manage symptoms like fatigue and brain fog. So we really want to be there to help people as much as we kind of rely on the medical side of things kind of sitting within primary care. Please do refer to us if you think that we can support people that are really struggling with persistent fatigue and fog. Don't know if there's anything else that either Ellie or Joan kind of want to add in there in terms of kind of key messages.
I would love to add in, just thanks, Helena, just real quickly that, there is good evidence for our post-COVID services, and it's just this last paragraph here for the family and friends test. In April 22, they tested for 146 participants who responded that, 93% rated the service as good or very good, and 97% said that they were treated with respect and dignity. 95% said that they were involved as much as they wanted to be in their care and treatment. So there is some real positive data going around for, the long COVID service. So please do continue to refer. Yeah, that's pretty much it from me. I don't know if we move on to the next slide unless someone else. Ellie, did you have anything to add? Otherwise, we'll move on to Q&A. So I think references are in the next slide, I think, Joanna. Oh, our details. So yeah, if you guys have any queries or questions, please do direct them to us. I would say we do have Wanu, the clinical lead OT, and also the 7 OT Denise with us from Barking Havering and Redbridge as well. They're on hand to kind of answer any questions that you guys might have. So please do, get in touch, or we'll also send out maybe their details as well. I didn't put it on the slide, I'm sorry. But yeah, if you have any questions, please just contact your local long COVID service. And I think the next slide is our reference. Q&A. There we go. So any questions?
I think there's one in the chat. Do you want me to read it out?
Yeah. Please.
It says, thank you, that was very helpful. Is the service likely to continue to be available for another few years?
I think this is different answers for different health trusts and boroughs. From Tower Hamlets and Newham, we're unsure. We're not sure. I'm hoping we'll find out this side of the year. We'd like to know as well. So I'm sorry I can't answer that question. I'm not sure if it'll continue on. I hope so. I really hope so. But at the moment, we are just waiting to hear back. I'm not sure about you guys in City and Hackney.
I think it's the $1 million question across long COVID services in the UK that because the funding was held by NHS England, and now it's coming into the sort of the local ICBs. So we're all trying to work out the best pathways, across the UK, and where services will combine with other perhaps chronic fatigue or post-viral services, or it's all up in the air at the moment.
And yes, certainly the same for BHR. It's all definitely a waiting game, and we're looking to hear more about, if it does continue, what type of service delivery or what the service delivery will look like, and what certain aspects will stay and what certain aspects will be taken away. But yeah, absolutely, it's down to the ICB, and a lot of fact finding, a lot of proof, data collection happening in the background at the moment. So that's the stage we're all at. Interesting. The next question, the next comment says, thank you so much. This is a question for the Hackney service. Is there a waiting list or rough expected time to wait post acceptance of the referral?
So once all the kind of like primary care assessments and sort of differential diagnosis is kind of completed, and we're in a position where we can sort of safely accept a referral for rehab input, we don't have too much of a wait time to kind of get people in. So we see people for an introductory webinar, which is a bit of information giving about kind of long COVID and what our sort of service is, what we and then if they sort of think that that's what we usually then sort of see them for a multidisciplinary assessment within 3 weeks, depending on which intervention pathway kind of is the best fit for them. After that kind of then the wait time is a little bit variable, but generally kind of I think our average wait time at the moment is between 6 and 9 weeks for sort of starting an intervention after that sort of.
Thank you very much. At the moment, there aren't any questions. I do believe somebody is typing. And I think the last comment is, would love and appreciate your feedback on today's session. Please do click on the link to give your feedback. It takes a few minutes. I think Sherifat has her hand up, and I'll hand over to her.
It's really hard to hear that. It's very quiet.
Is it better now? So who are our targets? Are we targeting the GPs or is therapy?
I believe it was for primary care, so GPs, but obviously welcome to all allied professionals, I believe.
Yeah, because the reason I'm asking this question is that the turnout is kind of encouraging. I did the presentation last month as well, and about just 4 people turn up, apart from myself and the 2 other people that did the. So because the thing is, if we are taking time to organize this presentation to educate them, create the awareness for this. If they are not turning up, then what is the point? It's not really encouraging. That's what I feel. So maybe I don't know what the issue is. Is it the presentation, or is it the publication, or what? Because the last time, the lady that coordinated said about 64 people show interest that they were going to attend. But at the end of the day, probably just 4 people. So it was like we're just doing the webinar for therapists presenting to probably 2 people, really 3 people, because one of them was the one. That's why
I might just come in there if that's all right. So I think obviously when you're sort of casting the net quite wide for a large kind of group of people across different trusts, it's really hard to find a time that's going to work for everybody. There will be lots of people that are tied up in clinical commitments. So I think one of the things, and correct me if I'm wrong, Joanna, but these sessions are recorded and then published on the NEL kind of resources kind of page. And I know one of our colleagues kind of presented at one of these previously, and while there was a sort of smaller live turnout in terms of those that accessed the recording and the resources kind of after the event, it was, I think, close to 100 or so. So it does seem to be kind of getting to people, but just perhaps not always in the sort of live formats. and hopefully that rings true for sort of like further sessions that have happened then.
Thank you for clarifying. So that's going back.
I believe we have a hand up from, I'm sorry.
Spots. Hi, is that me?
Yes, please. Yeah, that's you. Sorry.
Sorry, I don't know what my name says, if it says Spoz or Victoria. I'm not sure what it is.
Signorella.
Oh, Signorella, yeah.
Surname.
Yeah. Sorry, I couldn't work out how to change my name, but hi. Thank you so much. It's been so interesting to see, and I'm not a GP, I'm a therapist working in primary care, and looking at vocational rehab. So this has been really, really, really helpful, especially for the resources around of the fatigue management and the other bits. So I'm really going to go back and look at that. And I've spoken to a couple of people in the team at the Hackney service before, just to ask around. I think one of my biggest things is around, when do I stop as a vocational occupational therapist and refer into your service in terms of the fatigue management? And so I'm still working on that in terms of when is it appropriate to refer in, and ask the GP, sorry, for an assessment to refer in, or when is it up to me to just see if I can help them back into work and remain in work with these symptoms. So I guess my question is, are you guys seeing quite a lot of people for the vocational side of things at work, or are you tending to just see that overall as the main themes? Sorry if that's too broad.
I don't know if you, City and Hackney, you guys want to have a stab?
Yeah, sort of holding off phone, looking to Ellie. I'm happy to jump in, but I feel like maybe you might have a little bit more say here, Ellie. Go for it.
Yeah, and Joan, happy to hi, Spoz. Yeah, I think we are seeing quite a lot of people with vocational rehab needs, and I wonder a little bit. I think we haven't sort of formed kind of, maybe it's a bit of work to do around the pathway of when we see people. I think potentially we've got quite a few people who have maybe really, really been struggling to engage with work, or maybe have been on sort of really in and out of work quite a lot. Perhaps we've got, I don't know how you're able to work, but we've got kind of the capacity to see people, I guess, over quite a long period of time at the moment. I guess depending on what happens with funding, that might change, but at the moment we can see people for quite a long period of time and kind of work through a very phased return with them, if that's possible. I think we're seeing a lot of people really struggling to stay in work. And it's really hard. And I don't know, Joan, if you're doing much work rehab.
Fortunately not. We don't. I mean, your role, Victoria, sounds brilliant. We don't have a vocational rehabilitation service or therapist, so that sounds amazing that you guys have that funded. My question would be, do they have a diagnosis of long COVID, or are you in the process of kind of helping to support that diagnosis of the GP? Because I would probably start there, and then I would assume that perhaps there could be some overlap and some joint working between the two services, is my hunch. It sounds like it would be, pretty important to collaborate and to communicate quite closely with each other in regards to the patient, as I'm sure you have the skill set and your own resources as well that could complement your local long COVID service. But unfortunately in Newham we don't have any remit for vocational rehab. It's currently just myself, and we do have a 6 OT who is unfortunately off sick at the moment. So I wish we did have your role. It sounds like a dream thing. It sounds like a real great team to be having. So I would suggest possibly collaborative working and ensuring that they have the diagnosis of long COVID first.
Great. Thanks so much.
Yeah, I was going to echo that. I think the diagnosis is often really helpful in being able to implement, whether that advice is coming from you, Spoz, or if it's coming from rehab service. A lot of people sort of find that they might kind of have these conversations outside of a diagnosis, and getting the support and being able to actually implement the strategies and sort of processes that we might be kind of working through can be really challenging. And that's when kind of a diagnosis can fall in commission and backing up those kind of suggestions. I mean, we sort of looked earlier at kind of some of the barriers to kind of diagnosis, and it's really important to kind of have things like blood tests and chest x-rays and ECGs, but sometimes there are waiting times for those things. So we would almost lean towards kind of like getting that ball rolling sooner rather than later, so that that diagnosis, if it's kind of useful, is kind of a pipeline regardless of what is.
Yeah, brilliant, thank you so much.
Thank you
Karen,
for that.
thanks. Oh, I've seen Karen's questions in the chat. So yeah, I can just say a really brief thing about our cog interventions, our brain fog interventions, which is that both me and our OT have a background in neuro rehab. And I think, again, this is something which the way that long COVID teams have been set up, you've got so many different specialists. So I think that we've had a bit of a chance to develop things depending on our own interests and experiences. And I guess our offer I think there's heaps of brain fog and stammering and word finding issues that are coming up. And I think a lot of what we do is initially around condition management and fatigue management, because so many of and cognitive fatigue management, because so many of these issues seem to be worse with cognitive exertion. So we're doing a lot of this fatigue management work around as the kind of underlying, if you're exhausted and you're in pain and you can't breathe, you can't bring your mind to high level cognitive activities. Stammering is, I think, often associated with information processing speed, and so a lot of the work that we've been doing is this classic neuro rehab work of, well, let's notice, when is the brain fog worse, what are the situations that the brain fog's worse in, and then what is going to help in that. And that could be a variety of things, from a lot of the fatigue management things. Is it a psychological, is it an emotional thing that's going to help in that moment? Is it a preparing and a prioritizing and a planning thing that's going to help with the brain fog? I think people tend to just have quite a lot of good insight and manage things really, really well with a lot of strategies. So we do a lot of patients generating their own strategies and taking these on, because this is in lots of ways, quite a capable population with quite significant symptoms. There's a lot of ability to have quite a high level of knowledge and management of the condition. So hopefully that's helpful, Karen, but happy to talk more in more detail if that would be useful.
I wondered if I think also with the brain fog side of things, we get that often as well in neuro. We talk a lot about external aid, and when they're at the stage where they can no longer kind of rely confidently on their own memory and their own thoughts, especially sort of later on in the evening where the fatigue is kicked in, we're finding the brain fog kicks in as well. So actually they go hand in hand. But with the brain fog side of things, we are recommending a lot of external aid. So, notepads, papers, making sure that's close to their phone, notes on the phone, calendar on your iPhone, or physical diary. So just making sure that they have those aids, because what tends to happen is that they miss their appointments, they miss their health appointments. I've had a few one-to-one sessions that they've missed because they've just not remembered. So we are advocating a bit more for external aids and apps to remind as well. So lots of alarms, things like that. But in terms of what you said about a neuro rehab type service, I'm not sure if there is. I think it would just be, community neuro services, but they are long COVID diagnosed without a neurological background. It would just be probably the long COVID service, in which case in Newham, we don't have a dedicated cognitive stream of rehab. It would just be probably a quick screen or a cognitive assessment and then an onwards referral. Unfortunately, we just don't have the funding, the remit for it at all. Yeah, I hope that kind of adds to what earlier was and answers your question a little bit.
Yes, I just wanted to add, in BHR, we do with brain fog, we do very similar strategies as Joan just mentioned. We kind of approach brain fog from how to kind of manage it on a day-to-day basis within their occupations. But looking at brain fog itself, we have long COVID psychologists who are a team of, say, 3 people. They have assistant psychology practitioners as well, APs. And we have the opportunity, once they finish our Foundations for Recovery group, we refer patients on to that service, and they run a brain fog group. They also run a compassionate focus group as well, and so they really delve into the theories and the strategies to really kind of manage and look at brain fog and how it impacts them on a day-to-day basis. I wish one of the psychologists were here to let you know how that group runs and what they do in that, but yeah, that's how we kind of get around and address brain fog within BHR.
And I've just seen Karen's other question as well, just about an overlap with other neuro conditions. It's a funny one because I don't. We see a lot of mental health overlap. I'm not sure if you guys are the same at City and Hackney and BHR, but the cohort seems to be a lot younger. So it's the working population, your 20s, your 30s, your 40s. There's a lot of mental health. We're not seeing a lot of neuro. I've yet to have my stroke and long COVID patient, and I would love that. Like, my background is stroke as well. So honestly, I haven't seen it. I was expecting it as well. So this has come as a bit of a surprise, but I'm not sure if you guys are seeing some neuro overlap with long COVID as well.
No, I think lots and lots of anxiety about having an underlying neurological condition, but not sort of things which are like nothing's coming up on MRI or CT scans, like nerve conduction studies, you know. So no, and I wonder if they did have fatigue associated with MS, for example, or whatever, whether they'd be seen under the neuro teams more specifically.
Great. So I think that is the end of our Q&A. Does anybody else have any further questions that they may want to raise their hand up and ask? Feel free to unmute your mic. And if not, I can hand back. Will somebody type in? No. I can hand back over to Helena, Joan, or Eleanor.
I think that's us, isn't it?
Yeah, no, all good, I think. Thank you everyone for attending, and we hope you found it useful, and I'm sure the slides will be up on the websites. We'll hand you back to Joanna.
Thank you so much. It's been a really great session. So what we'll do is we will share the recording link and the slides with everybody, and it will be up on the NEL Training Hub website. So if you want to refer back to anything, you can do. But I think that brings us to the end. So thank you so much to our speakers today and everyone for attending, and have a lovely afternoon.
Perfect. Thank you.
Thank you so much.
Bye.
Thank
Bye.
you.
Thank you. Bye.